all know that the goal of treatment in this forearm fracture is that you want to have a good union without causing any cosmetic deformity or any forearm stiffness. So again, we have a confusion whether to treat it just by plaster and conservatively or by surgery. So there are various factors which can decide your choice of treatment. One is, of course, the age of the patient, but it also depends on what is the pattern of fracture, like whether it is plastic deformation, green stick fracture, or a complete fracture, comminuted fracture. What is the time since injury, the amount of displacement, how stable is the reduction? All these factors are going to decide how you're going to treat your forearm fractures. So there's a very good article published recently, and where they have said that they have seen 11 years follow-up after non-operatively treated forearm shaft fractures, and they've said that all show very good long-term recovery. And say it's mentioned that the operative treatment unfortunately has increased almost by 60% in recent years. The reason being cited is that there is twofold greater rate of immediate complication after plaster, which is more in form of redisplacement up to an extent of 40%, residual deformity, compartment syndrome, and in long term with cast treatment, you can have loss of rotation. But they mentioned that this is solely because of the forgotten art of conservative treatment. So I'm going to talk about how can we treat conservatively in a good manner forearm shaft fractures. So after plastic deformation, which Premal has already talked about, let us see what is green stick fracture and how do we manage them. So as we know, it's an incomplete fracture involving only one cortex, but the opposite cortex is intact. Must understand that here the mechanism of injury is purely a rotational injury. So if you have a supination injury, it leads to a volar apex angulated green stick fracture. And if you have a pronation injury, it leads to a dorsal angulated green stick fracture. So the method of reduction is just a derotation maneuver. You don't require significant traction and manipulation. You just have to derotate. So if it's a apex dorsal, you just supinate and you get a wonderful reduction. As against if it's a apex volar, then you pronate. And a simple thing to remember, which is mentioned by Noonan and Price, is to rotate the palm towards the deformity. So if your deformity is volar, you rotate it like that pronation, and if it is dorsal, you supinate it. So it's just a simple derotation maneuver by which you can get a good reduction and then you can immobilize in a good cast. Important thing to understand is this radius crossover sign, which can indicate that whether your green stick fracture is mal-reduced in terms of rotation or no. So all of you look at your forearm, and when your forearm is in supination, you see how, if you take an X-ray, how does the X-ray look? Two bones, radius and ulna, have not crossed over, and the relationship between them is to be seen at the elbow and the wrist. Now, if you make the forearm in neutral position, then the radius crosses over the ulna in the middle third, and at the wrist level, both the bones are overlapping each other. Now, if you pronate completely the forearm, then the radius crosses over the ulna in the proximal third, and at the wrist level, the relationship is completely 180 degrees to what it is at the elbow. So this is how your normal forearm looks in different rotations. Now, when you see a post-reduction X-ray, you have to analyze it in terms of how does your X-ray look above the level of the reduction and below. So now this is a fracture which is a post-reduction X-ray. Now here the radius is already crossed over. That means the proximal fragment is in pronation. But if you look at the wrist, the two bones are overlapping and it is not completely changed. So this portion of the forearm is in neutral. So proximally it is pronated, here it is in neutral. That means it's a mal-reduced, mal-rotated reduction, and you should not accept this and take it for re-reduction. So if you understand the green stick fracture well, reduce them well, analyze your post-reduction X-ray well, then you can have a good reduction and good outcome. Coming to complete fracture, while deciding the treatment, you must assess the age of the patient, what are the bones involved, whether it's only radius or radius and ulna, what is the level of fracture, the amount of displacement, angulation, shortening, all these factors need to be analyzed on your primary X-ray and then take the decision. Here the reduction involves under anesthesia, we have seen it in the morning, you exaggerate the deformity, apply traction, and based on the amount of angulation displacement, you reduce the fracture and then check the X-ray on the C-arm. Again, you must be aware of what is the acceptable limit, very well described by Price et al. So less than 8 years, you can accept up to about 15 degrees of angulation and 45 degrees of malrotation. But as the child matures, nearing maturity, you have a very limited margin of acceptance. So you must remember this and have your reduction within this acceptable limitation. Important thing again, just like in green stick fracture, is to understand how you assess your post-reduction X-ray, because you want to achieve an acceptable reduction. So I always remember this mnemonic broad. So analyze your X-ray on these 5 headings. See what is the bow of radius, what is the rotation, how much is the overlap, what's the angulation, how much is the displacement, and see whether you have achieved all these components within the acceptable limits. So normally, if you, from anatomy, we know that the site of maximum radial bow should be at 60% of the radial length, and the maximum amount of bow should be below 10% of the radial length. So you should achieve this on your post-reduction X-ray. Regarding rotation, as we talked in the morning, see where is your bicipital tuberosity, and see your radial styloid. They should be at 180 degrees to each other in the AP view, and on the lateral view, the ulna styloid and the coronoid again are at 180 degrees to each other. That will give you an idea about a rotation. Less than 1 centimeter of overlap or shortening is acceptable in either single or both bone forearm. So if you have not achieved complete length, but if this much of overlap is there, again you can have a good result and you should not worry about it. Acceptable angular alignment is going to be different depending upon the level of the fracture. In lower third, you can accept up to 20 degrees, in the middle third up to 15 degrees, but in proximal third, it's only up to 10 degrees, and this provided you have at least 2 years of growth remaining, where this much amount of angulation can remodel and you can have a good final outcome. Finally, complete displacement or translation in the upper and middle third are known to reliably remodel. Even bayonet reduction is acceptable, but it is difficult to maintain, and it's been shown that almost 30% of them have redisplacement and malunion. So if you are accepting bayonet reduction, be very vigilant in your post-op protocol. Once you have got an alignment and a reduction within acceptable limit, the next step is to give a good cast. So you should have a well-molded cast with elbow at sharp right angle, with straight ulnar border, with correct 3-point and intraosseous molding. And there are various indices described for these forearm and distal radius fractures, but the most commonly what we use is the cast index, which is the inner diameter of the cast on lateral, divided by the inner diameter on AP view, which should be less than 0.7. And there are these various other indices like padding index and 3-point index. So your cast should be good enough so that whatever you have achieved, what reduction, that should be maintained in your follow-up. Because such things are very common. You see a good reduction immediately at 1 week, the fracture starts again angulating, just like in pre-reduction. At 2 weeks, it is still more. And if you don't undress at the right time, then ultimately you lose the reduction and have a malunion. So you should have weekly follow-up, and cast should be continued at least for about 6 weeks. So what happens if you see on follow-up that you are losing your reduction? Is there a place for cast wedging? So this paper in JPO describes that yes, if it is isolated varus valgus or apex anterior deformity, you can do a cast wedging. Should always have an open wedge cast, and up to 5 degrees of angular correction is possible. It's an OPD procedure, can be done without anesthesia, and it is quite simple and having 90% success rate. And a wonderful article published by Dr. Sheetal Parikh and group in JPO 2016, where they have advised re-reduction for redisplacement of both bone forearm shaft fractures. And they've extensively studied, and they have said that there are certain predisposing factors for redisplacement. Some are inherent to the fracture, like if its age is more than 10, or if it's a complete fracture, or if there is greater initial displacement, or if it's a radius ulna fracture, more likely to redisplace. But some of them, or in fact majority of them, are surgeon dependent. So if the surgeon experience is less, you do it in the evening hours. If you don't get a good reduction initially, or if you're poor cast, you have a poor cast, then they can redisplace. And they have actually studied what is the cost benefit ratio. So surgery is more morbid, more complication, and more expensive, almost more than 2 times. And they've also advised to do remanipulation, which can be a safe and effective treatment to maintain the reduction. So to summarize, closed reduction for forearm shaft fracture is still the gold standard. In plastic deformation, you require reduction under anesthesia with a lot of force. Green stick fracture, it is important to de-rotate during reduction. For complete fracture, you must pay attention to the criteria of acceptability. And frequent follow-up and maintenance of reduction by a good casting technique is important. You do have place for operative treatment, but in limited indications, which I think my next subsequent speaker will tell you. Thank you so much.